I'm trying to work technology.
Wait, do I share screen or do I share my computer?
Share screen.
Share your screen.
Like share the screen with the slides.
Okay, I'm gonna like that.
Oh, that's your full computer. I mean, it's fine. It's the same.
Just present it. Yeah, just present it.
It doesn't really matter too much.
Okay. Okay. So welcome everyone. We're going to be finishing off endo today. We'll start off with thyroid and then move on to parathyroid, and then we'll finish off with adrenal pituitary axis. So thyroid's pretty big. It's pretty important, but it's pretty simple. It's pretty simple. So we'll just get started. We'll start off with basic anatomy and then move on to physiology, and then pharmacology and like pathology. So we'll do it in kind of a one big chunk. So we'll start off with the anatomy of the thyroid. So the thyroid is one of our main endocrine glands. It sits in our neck between C5 and T1 vertebrae. They're pretty good landmarks for where the thyroid gland will sit. And it wraps around our cricoid cartilage. So we can see here that we've got our thyroid cartilage, and then we've got our cricoid cartilage below it, and then we've got the thyroid wrapping around the cricoid cartilage, as well as our tracheal rings. We've got two lobes. We've got a left lobe and a right lobe, and it's connected by this isthmus, which is sort of like a bridging kind of like anatomical structure, I suppose. And that will wrap around these tracheal rings and the cricoid cartilage in this butterfly shape. So you can see like the two wings are here and like the body is kind of in the middle. Occasionally we have this third pyramidal lobe, and you can sort of see it in this picture as like this extra little lump. Sometimes it extends a little bit further, but that has sort of embryological origins, which we'll talk about a little bit later. But it's a remnant of one of the original structures in how the thyroid descends from the mouth. So as the thyroid descends from the mouth, you can imagine that there's almost like a connecting link, like a, what would you call it? I guess a rope that it ascends down. And as the rope stretches, if it doesn't fully obliterate, you get this remnant lobe that sits either on the left or the right lobe. So the thyroid sits within the neck. It's surrounded by this pretracheal fascia. And within that pretracheal fascia, we also have our trachea, esophagus, and pharynx. So you imagine if we get pathology within the thyroid, say if it's swelling or there's hemorrhage, we can get a lot of compression of these other structures. So we might get compression of the trachea, causing respiratory symptoms like dyspnea, or we might get compression of the esophagus, causing dysphagia or gyneaphasia. So you can imagine that the pathology of the thyroid has implications on other structures based on its anatomical location. So that's the significance of knowing that it's surrounded by the pretracheal fascia. Above the thyroid, we imagine we have our neck muscles. So the most important ones that sit directly above the thyroid are the sternohyoid and sternothyroid muscles. And that's relevant when we're looking at surgical options when we're treating thyroid disorders. Say if we need to do a thyroidectomy, if we need to remove the thyroid, we need to cut directly through these muscles. And that can be also a common question that they'll ask you, what muscles need to be cut through in the neck when performing a thyroidectomy? And you'll have to know sternohyoid, sternothyroid. Great.
I think it's also good to know that the sternohyoid, right, goes from your sternum to your hyoid bone, which is kind of here. And then the sternothyroid goes from your sternum to your thyroid cartilage. And that sternothyroid is the muscle that limits upper extension of your thyroid gland. And that means that when it enlarges, it doesn't go upwards, it goes like down and kind of posterior. And so it's more likely also to compress like your trachea, your esophagus, and your pharynx.
Yeah, this will also come up again in neck SEMS anatomy as we do neck anatomy, which is probably where it's more
it's also
easy to understand. Yeah, okay, moving on. So this is like a picture. We can see we've got the two lobes connected by the isthmus. We've got our thyroid cartilage sitting above, the cricoid cartilage below, and then our tracheal rings. We can see it's supplied by arteries and vessels and veins, which we'll talk about in the next slide. But this is sort of just a general outline of everything going on over there. vasculature. So we'll talk about it in terms of arteries and veins. So we've got our superior thyroid artery and our inferior thyroid artery, which supply the thyroid gland. So the superior thyroid artery comes off our external carotid, and as you imagine, superior supplies the anterior superior aspect. And then our inferior thyroid is coming off our thyrocervical trunk, which is coming from the subclavian artery. And that's going to supply the inferior aspect of the thyroid. So they make sense when based on the name. And then we've got our venous drainage. So instead of 2 arteries, we've got 3 veins, which is a little bit different. And they all form this sort of anastomotic plexus around the thyroid to drain the thyroid. It's pretty highly vascularized. So it's got pretty strong blood supply. So you can imagine if there's any disruption to this, you're going to get a lot of hemorrhage within the pretracheal fascia. So you've got your superior and middle thyroid vein, which are both draining to the IJV. And then you've got your inferior thyroid vein, which directs your brachiocephalic veins. Okay, recurrent laryngeal nerve palsy. So the thyroid sits in very close relation to the recurrent laryngeal nerve. So as they come off the vagus nerve, the right recurrent laryngeal nerve will hook around the subclavian artery, whereas the left one hooks around the arch of the aorta. And then they'll run through that through the pretracheal fascia underneath the thyroid gland. So imagine if you have any pathology of the thyroid gland, or even if you're performing surgery on the thyroid gland, you might be damaging. You're in very close proximity to those recurrent laryngeal nerves. So if you're a bad surgeon and you accidentally damage it, or even if you're a good surgeon, you might accidentally damage it just because it's such a fine structure. You might cause hoarse voice or lost voice. Hoarse voice is generally if you're damaging 1, lost voice is if you damage 2. Because the laryngeal nerves, they supply those pharyngeal muscles for like vocal phonation and things like that. Yeah. So embryology of the thyroid gland. So how does it come about? So development starts in approximately week 3 in the primordial pharynx, so in this upper mouth head region. So it begins at the foramen cecum. So that's like a little bit of a hole, like a kind of a hole in the mouth, and it sits in the midline between the anterior 2/3 and the posterior 1/3 of the tongue. And the thyroid sort of buds off this foramen cecum, and it descends down this thyroglossal duct. It will be on an image later, but it migrates inferiorly anterior to our hyoid bone, which makes sense because it's anterior to all those cartilages as well. And as it develops, it sort of lengthens along this cord, which we call the thyroglossal duct. And as it descends to its final location, the thyroglossal duct is eventually obliterated. But in some people have like this pathological pyramidal lobe, and that's about 50% of people. So it's more common than you think. Yeah, so this is a pretty good picture. We've got the foramen cecum, we've got the thyroid diverticulum. So it's sort of like a little bud at this point in week 1. And then by week 3, it starts to descend into like a real thyroid. And you can see how there's like this long cord-like structure, which connects the foramen cecum to the thyroid gland. And as we develop further, eventually it breaks down, leaving just the thyroid to sit around the cricoid cartilage. Yeah. So histology. So
This is a point on the embryology. So again, the embryology will come back a lot more next semester when you talk about head and neck embryology. But I think the really kind of useful thing here is talking about the thyroglossal duct, because it has like relevance later on when Gavin starts talking about the exam. So that's kind of the one thing that I will talk is kind of important to know. The ins and outs, the nitty gritty, I don't think is like very, very assessed in semester 1, but it will come back in quite a lot more detail in semester 2. Just the thing.
Yeah, exactly. Okay, so histology. So histology is pretty important for the thyroid gland, but I think it's not super hard to differentiate thyroid from other endocrine organs just because it's got a sort of a unique kind of look to it. This is generally what a thyroid gland. So you've got your follicle, your main thyroid follicles, which sort of contains most of your T3, your thyroid hormones, as well as your thyroglobulin. And that's sort of like the vast majority of the thyroid gland. That's where the big sort of large amounts of contents are sitting in there. And that's surrounded by sort of this large capillary network. So around your follicle, you've got your follicular cells. So around there, you can see like a little bit of epithelium that sits around your follicles. And then between those follicular cells, you've got your interfollicular space. So you've got your parafollicular cells. And that's got your, or they're also known as C cells. And they secrete calcitonin, which isn't actually relevant to your thyroid hormones, but it's more relevant to calcium. So as Kevin will talk about calcium and stuff later on, but your main calcium hormone is your PTH, which increases your blood calcium. Calcitonin sort of opposes that and lowers your blood calcium. And it does that through a few mechanisms, but mainly by inhibiting your bone resorption and maybe also possible GIT absorption of calcium. Yeah, so those follicular cells that we were talking about, they're mainly either simple squamous and simple cuboidal. It's a mixture of both, so it's hard to say it's one or the other. And even there's variation between most people in how the quantities of each. So it's really just a mix. Yeah. Within the follicles, you've got your thyroglobulin as well as your T3 and T4. Your thyroglobulin is actually, it acts as like a storage and a reserve. So you've got about a 2 to 3 month supply before it kind of runs out and you're going to have thyroid problems. If you ever are in sort of an iodine deficiency, you ever run out of like the contents you need to make up your thyroid hormones, basically. And this thyroglobulin is eventually going to form your final T3 and T4 products. And we'll talk a little bit about its formation later. But yeah, just be able to rate. This is quite a common picture they actually use in like the actual quizzes. So you can see you've got your follicles. They kind of look like, to me, they look a bit like adipose tissue. But they're kind of like these big blobs and they contain your colloid. Around them, you've got your epithelium, and between them, you've got your parafollicular C cells. And that's pretty much all you really need to know about histology, I think. Yeah. Okay, so thyroid hormone synthesis. So we'll look at the picture first, and then we'll walk through it in words. So the first step is your iodine. It comes from, your thyroglobulin, which is sort of your precursor. It's going to be synthesized in your rough ER, and it's going to move from your follicular. So this is all in your follicular cell. It's going to move from your follicular cell into the follicular space. That's the first step. Second step is kind of completely different. Your iodine is going to move from your capillaries. It's going to move through into your follicular cells, and it's going to move back into the colloid, and it's going to combine with your thyroglobulin molecules to form either diiodothyronine or monoiodothyronine. And it'll form one or the other based on how many iodine molecules are actually combining with it. Those will come into the cell. They'll be endocytized from your colloid space back into your follicular cells. And they'll be combined to either form T4 or T3. So if you've got a DIT plus an MIT, you're going to get T3 because you've got 3 iodine molecules there. If you get a DIT plus another DIT, you're going to get a T4. And that's where like the naming comes from. And then it will get cleaved and sort of processed, packaged in vesicles, and then it'll be exocytosed back into your bloodstream. So we'll talk through it again just through words to help people who don't learn through diagrams. So you've got your thyroglobulin synthesized in your rough ER in the follicular cells, and then it's going to move out into the follicular lumen, into that colloid space. While this is happening, iodine is also being transported from your bloodstream into your follicular cells and then back into the follicular lumen as well. So now you can imagine you've got your thyroglobulin and you've got your iodine in your follicular lumen. Iodine is then combined with a tyrosine part of the thyroglobulin molecule. And whether it's one iodine molecule or 2 iodine molecules, just depends on chance, I suppose. And bodily functions, we don't really need to know about that, but you can either get one or the other. And then they'll be combined as they get endocytosed back into your follicular cells. And as they're combined with the lysosome, they're processed into their final form, and then they'll eventually just diffuse into the bloodstream. Yeah, so I think pictures are probably the best way to learn it. Yeah. Okay, so T3 and T4, what's the difference? So as we said before, T3 contains 3 iodine molecules and T4 contains 4 iodine molecules. while T3 is more abundant, more potent, it's a stronger version of the thyroid molecule. It's less abundant, and T4 is kind of the opposite. So you can kind of think of them on like two sides of a spectrum. Actually, just two sides. It's not really a spectrum. It's just one or the other. You don't really get in between. So while your T3 is more potent, your T4 is less potent, and while your T4 is more abundant, your T3 is less abundant. Your T3 is 96% bound to plasma proteins, whereas your T4 is 99.6% bound to plasma proteins. So that means a lot more of your T3 is just sitting in your blood as biologically active, so it can just act on receptors in the body, act on its target cells, where a lot more of the T4 is just sitting attached to either your thyroglobulin, so your binding protein. Because T3 and T4 are like steroid hormones, they mainly bind to plasma proteins. They can't just sit, a large quantity of them can't just sit in the blood because the blood is hydrophilic and these will be hydrophobic. Because a lot more of your T4 is bound to plasma proteins, a lot less of it is going to be excreted and processed, because a lot less of it is sort of being protected, I guess, by the plasma protein. So it's got a longer half-life. It'll have a longer, it'll take longer to break down in the body, whereas T3 will have a shorter half-life because it's more biologically active, because more of it's sitting unbound to plasma proteins. T3 has a smaller pool, whereas T4 has a larger pool. And that sort of comes off that idea that it's more abundant and less abundance. T3's got fast turnover, mainly because it has a shorter half-life, and T4 is the opposite. It's got a longer half-life, so lower turnover. So it'll take a longer time for it to be used up in the body. And then here are just some statistics about T3 and T4 synthesis, which is actually kind of pretty important. So about 1/3 of a T4 is actually going to be converted into T3, and that will happen in the peripheries of the body. And that's because it's more potent. It's a stronger hormone, and so we need less of it to be acting, to be having an effect on our bodies in order to execute its metabolic functions. And that links in with our T3. So 80% of T3 is coming from our T4, and only 20% of it is going to be coming through our thyroid gland. So a lot of it's actually coming from that peripheral conversion of T4 to T3. And that's mainly happening in the liver. Okay, other relevant biochemistry. So T3 and T4, they mainly act on their thyroid receptors. They're also known as steroid or retinoic acid receptors, and they'll be affecting gene transcription. And that's how they'll have their effects. We can also have reverse T3. So we can see we've got our normal tyrosine molecule. We'll add our iodine molecules and either turn to thyroxine, which is T4, or triiodothyronine, which is T3. And then we can also have reverse T3. So as opposed to our iodine being over here, it's over here. And that will have a different effect. It's sort of a, it works in opposition to our thyroid hormone by blocking the action of thyroid hormone. So it's basically just the opposite. It kind of slows down the effects of our thyroid hormones if we need to. Yeah. Okay. So transport of thyroid hormones. As I said before, a lot of our thyroid hormones are basically steroid hormones, and they mimic the properties of steroid hormones. They can't just sit in our body, just floating in the blood, because that doesn't work. It's not biochemistry. It doesn't follow biochemistry, the laws of biochemistry or whatever. So it needs to be bound to plasma proteins. And the main one is our thyroxine binding protein, so TBG. We've also got albumin and thyroxine binding free albumin, but they're in much smaller quantities. Our main one is this thyroxine binding protein. And it again protects it from excretion, because if it's sitting on our plasma protein, it's not going to be excreted through our kidneys, because it can't get through, if we remember from last week, our glomerular filtration membrane. It can't get through there because it's a large protein, right? And that stops us from having sort of these wild fluctuations in our thyroid hormones, because we know only that small amount is going to be changing or being excreted at a time. So we can kind of keep a stable level of our T3 and T4. And it's important to know the factors which affect our thyroid binding protein. So a lot of it's based on estrogen. If we have high amounts of estrogen, that's in pregnancy or when we're taking the OCP or just estrogen hormone therapy in general, hormone replacement therapy, then we get increases in our thyroid binding protein. And if we have sort of illnesses that are going to affect again, our excretion. So if we're getting a lot of excretion of our protein, or if we're having liver disease, which isn't producing as much of the thyroid binding protein, then we're going to have less thyroid binding protein. And then major illness, I'm sure that's a cause of everything under the sun, and it'll affect bodily functions in a whole bunch of ways. Yeah. Okay. This is a very blurry diagram, but a diagram nevertheless. But it basically just shows that even though we have high amounts of albumin, a lot more of our T3 and T4 binding is going to be binding to our TBG because it's got a high affinity for it. So a lot of it's just binding to our TBG. Albumin's relevant, but not that relevant. And DBPA is even less relevant. Okay, so peripheral deiodination. So this is what I was talking about before when we were talking about how T4 is converted into T3. And that's mainly going to be happening in the liver and kidney. So that's removing one of the iodine molecules. So if we remove one of our iodine molecules, we're going to get either T3 or reverse T3. And that depends on which part of the molecule it's been removed from. You don't really need to know, but if you feel like knowing, if you're very interested in the thyroid, if you love the thyroid, here's the information. If you deiodinate the inner ring, you're going to get reverse T3. If you deiodinate the outer ring, you're going to get normal T3.
So like the significance of reverse T3 is that it like antagonizes the receptor, right? So if you have too much reverse T3, then the thyroid hormones don't work as well. But essentially, that's basically all you really need to know about it.
Yeah, just to like balance out the thyroid hormone effects.
Mm.
Okay. Metabolism of thyroid hormone. So we've already kind of touched on this a little bit, but we'll keep talking about it. So T4, again, has a longer half-life because more bound to our plasma protein, so it's more protected from excretion. Half-lives are decreased in hyperthyroidism, and half-lives are increased in hypothyroidism. I looked it up, and I'm not actually too sure of the mechanism on it, but it was in the lecture notes. So I guess roll with that. But yeah, I don't think it's super important to know, to be honest, unless anyone else has an idea, but I couldn't find it on any like research or anything. Nope.
Probably just based on what the underlying cause is of the hyperthyroidism or the hypothyroidism. Yeah. But it makes sense that if you have autoantibodies against them, then the half-life would be decreased, things like that.
Yeah. Okay. And then we'll talk about what our T3 and T4 is actually doing. So the way I like to think about it is basically if your thyroid hormones stimulate most of our body function, they kind of like just ramp up everything. And they do that by mainly through our basal metabolic rate. So you've got this increased activity of your Na and K plus pump, and that sort of will have flow-on effects to increasing your ATP production and stimulating your mitochondriogenesis. It's all about increasing our ATP production. And that will link in with all of these metabolic actions. So we're going to be increasing our protein degradation so we can be synthesizing our ATP. Same with our lipolysis, our CHO, our carbohydrate absorption, and our gluconeogenesis and glycogenolysis. And we use that so we can carry out sort of our bodily functions if we need to like ramp up. If we're almost mounting sort of a sympathetic response, we're going to be increasing our NMJ transmission. We're going to increase our CNS activity, tissue growth, all those kinds of things. It's kind of like building as well as working out. Like if you imagine going to the gym, that kind of thing. That's how I kind of imagine. But it's got a sort of a broad range of effects. Yeah. This kind of highlights the range of effects in the body. So it's important to note that in terms of protein and especially your fats, while you're having protein synthesis, the protein degradation is a lot higher. Same with your adipose tissue. Your lipogenesis is still happening, but you've got a lot more lipolysis happening. So you get your net lipolysis and your net proteinolysis. And that's going to be supplying the energy for your body functions. Yeah. Okay. So thyroid stimulating hormone. So this is talking in reference to our negative feedback loops. It's probably a little bit easier to understand with the picture, but basically we've got our hypothalamus, which produces thyroid releasing hormone that will act on our anterior pituitary gland, and that to stimulate thyroid stimulating hormone. Thyroid stimulating hormone will act on the thyroid gland to stimulate T4 and T3 production. And T3 and T4 production will negatively feedback on both the hypothalamus and the anterior pituitary gland to regulate the level of thyroid hormones in the body. And that's what we call the thyroid axis. And it's pretty much it's a pretty standard negative feedback loop. So I don't imagine you guys would have too much struggle in learning that. But there are a few other things to be aware of which affect the thyroid axis. So some of the main ones we talked about, again, our thyroid hormones. Cold. If it's cold, we're going to be secreting more TRH and then TSH and then thyroid hormones. Circadian sleep. So if we're in our circadian sleep rhythms, mainly between 12 a.m. and 4 a.m., we're going to be secreting more thyroid hormones. And if we're starving, we're going to be inhibiting our TSH production. But if we've got excess food, we need to burn off that food. We need to be using up all those calories that we're eating. So we'll be stimulating our TSH production to be breaking all those foods down, basically. Fun fact about osteoporosis, I suppose. Not that important. Okay. So hyperthyroidism and hypothyroidism. So these are going to be the two main pathologies that you really need to focus on and kind of know pretty well, I would say, because these will form the basis of a lot of pathology questions, your exam, and your history. So it's good to know them well, and they'll always come back in later years, I'm sure. So hypothyroidism, also known as thyrotoxicosis, but that's by old people. So we call it with overactivity of the thyroid gland. So we're going to be producing too much T3 or T4 hormones. We can classify it into either primary hypothyroidism and secondary hypothyroidism based on the level at which the pathology is. So whether it's our thyroid gland that's fucked up or whether it's our pituitary gland that's messed up. Pardon my language. So the way I like to think about it is no matter what kind of hypothyroidism, you're going to be having too much T3 and too much T4. So if you imagine you've got too much T3 and too much T4, you're going to be having a negative feedback loop, and your anterior pituitary gland is going to be trying to limit the amount of T3 and T4. And so it's going to be secreting low levels of TSH, but your thyroid gland is going to be responding to that. It's like, nah, I don't know what's going on. I'm a little bit going off on my own, and it's not going to respond to that. So it's still going to have high T3 and T4, regardless of what the anterior pituitary gland is doing. So these are the two findings that you have if someone's got primary hypothyroidism. If someone's got secondary hypothyroidism, that means there's something wrong with the pituitary gland. So we're still producing high T3 and T4 from our thyroid gland, but our pituitary gland isn't responding. It's not working. It's not functioning properly, and it's not listening to our negative feedback loop. So while it should be producing our low TSH levels, in fact, it's going to be producing high TSH levels. And that's what's going to be stimulating our high T3 and T4 production from the thyroid gland. And that's sort of one of the main concepts to know. They'll give you like certain T3 and T4 levels, like whether it's high or low, and they'll give you TSH levels and say high or low, and you'll have to identify whether it's primary or secondary hypothyroidism, and same for hypothyroidism. So there's a few different causes of hypothyroidism. We've got Graves' disease, which is an autoimmune disease. We've got toxic nodules, and we've got thyroid tumors. The main one that they'll quiz you about is Graves' disease. And usually they'll be able to give you a clinical scenario, and it'll be a young woman in our fertile years who sort of got these prominent eye signs. She's got these bulging eyes and like a big lump in her neck. And she'll be coming with like anxiety, sweaty, that kind of thing. And you'll be like, that's Graves. I know that. Gavin said that. Graves' disease. Okay. So we'll talk about Graves' disease.
So we had a question.
Yeah.
We had a question. And it goes, when is the best time to test for TSH and T4? Unless you guys know of a specific time, I had a quick Google. I couldn't find anything. So I don't think there is a specific time for TSH or T4 it's the best to test for.
Random, I think.
Pardon?
I'm pretty sure it's just random.
Yeah.
As in like
so
time of day?
Yeah, as in time of day.
Okay.
Yeah.
I think it's
the thyroid hormone levels, they do fluctuate throughout the day, and like Gavin said, they're highest in like the middle of the night. But there's not really like a prescribed best time to test for them. You just sort of like ideally you just want to pick a consistent time, so you're not like getting a random midnight test, because obviously that's going to show very high levels. But if it's relatively consistent, relatively under the same conditions, there's not really a set time that is best. It's similar with cortisol. Cortisol levels also fluctuate throughout the day, but they do actually prefer to do like morning cortisol levels and stuff for accuracy. For some reason, thyroid, they just don't care as long as it's relatively consistent.
Yeah, I haven't heard anything about specific time of days. Yeah. Okay. Keep moving. So Graves' disease. So again, as I said before, it's an autoimmune disease where you got your antibodies and they're going to be stimulating the TSH receptors on your thyroid. So they're not actual TSH molecules, they're antibodies which are just stimulating the TSH receptors. And that's going to be stimulating your thyroid to produce excessive hormones. And likewise, it'll cause that negative feedback on the anterior pituitary gland, because the anterior pituitary is working fine and it's going to have low TSH. It's going to be producing low TSH levels because of that. Signs and symptoms. So we've got our increased basal metabolic rate. So we're going to be burning a lot of our fat and muscle. So we're going to get weight loss and muscle atrophy. We're going to have fatigue, because every disease causes fatigue. We're going to be having heat intolerance. So heat intolerance is mainly to do because we're burning so much of our fat, because our body is working so hard. When it's hot outside, we are less able to tolerate that because we're already so hot. So that's why they get that heat intolerance if it's just like a mild change in temperature. We've got increased sympathetic response. So we've got our sweating, tremors, tachycardia. Because we've got our like long-standing tachycardia, there's an increased risk of atrial fibrillation. So the heart to go into sort of this, fibrillating mode where it's beating too fast, it's not contracting properly, and it's out of sync. It's very irregular. And our brisk tendon reflex, because we've got that increased sort of synaptic transmission at our neuromuscular junctions. We've got a goiter that can be associated with high TSH. So if there's more commonly in secondary hypothyroidism, but also like it's not completely fully understood how goiters work. So it also happens in Graves' disease as well. But it's where you've got this big lump in your neck. That's basically what a goiter is. Eye signs, so you get bulging of your eyes. That's what proptosis and exophthalmos mean. They're very like sort of pathognomonic for Graves' disease. If you see exophthalmos or proptosis, the answer is probably Graves' disease. Diarrhea, because you're getting a lot more stimulation of your gut, you're pooping it all out basically. Things are happening a lot faster. Amenorrhea is kind of the one that doesn't really fit in with the picture of like heavy diarrhea, heavy sweating, all those fluids. You actually get like a irregular period where it's nothing's really coming out there, which is sort of just the one to be cautious of and like keep in the back of your mind as like, exception to the rule kind of thing. Okay, so now we've got hypothyroidism. So
just quickly, another question.
Yeah.
So Savannah's answered it. But the question went, if it's stimulating the TSH receptors, will the test result be high TSH and high T3-T4, or would it be low TSH and high T3-T4? So the answer to that is be high T3-T4 and a low TSH, because how Graves' disease works is it's like an antibody that binds to the TSH receptors, right? So what you'll get on a test is you'll also test that antibody. So the anti-TSH antibody, I don't know what actually it's called, but you'll look for that and it'll be raised, but you won't get an increased TSH because there's not being more TSH being made. That antibody is activating that TSH receptor, if that makes sense.
Yeah, exactly what Kevin said. It's not it's not a TSH molecule itself, it's different, but it's mimicking the effects of TSH. So you get your low TSH and your high T3 and T4. Any other questions? Or we good?
I think we're good.
Okay, sweet. Okay, so hypothyroidism is pretty much the opposite. Sits on the other side of the spectrum. So it's, as opposed to overactivity, it's underactivity of the thyroid gland. And again, we can have our primary hypothyroidism and our secondary hypothyroidism. So with both hypothyroidism, you have low T3 and T4. Did I write TS and TS? Okay, I'm going to change that in the slides. But it's T3 and T4. If your pathology is at the level of the thyroid gland, so say if the thyroid isn't messed up and is producing low amounts, is still going to be stimulating our anterior pituitary to stimulate high levels of TSH, but our thyroid gland isn't going to respond to those high levels of TSH, and it's still going to produce low amounts of T3 and T4. But when we have secondary hypothyroidism, the pathology is at the level of our pituitary gland. So if our thyroid's producing low amounts of T3 and T4, it's going to negatively feed back on our pituitary gland, but our pituitary gland is not going to respond to that negative feedback. So whilst it should be producing high amounts of TSH and TSH to stimulate our thyroid gland to like ramp it up a little bit more, it's not going to be doing that, and it's not going to be working properly. It's going to be stimulating low amounts of TSH, and that's why the results are like that, I suppose. There's a few different causes of hyperthyroidism. One of the most common ones is Hashimoto's disease. So that's where you get your sort of autoimmune antibodies causing just damage to your thyroid gland. And inflammation is just going to cause it just not to function properly because it's cellular death, and less amount of thyroid active properly functioning thyroid cells. You can get congenital hyperthyroidism. So this can just be like if a baby isn't properly producing their thyroid hormones, or if they don't even have a thyroid gland, and that can have really adverse effect on development and growth. Because thyroid hormones are really important for a baby's development and growth. They can become mentally retarded, and they associate with this condition called cretinism. You can kind of search it up, but it's where the baby basically looks like a goblin, and it kind of like doesn't really grow properly. I think there's another question, but I can't open it.
Oh yes. Our tutor said Hashimoto starts with hyper and then ends up being hypothyroidism.
Yeah. So yeah, exactly. Hashimoto's. There's variation in how it presents. So it's not always like it's like this continual downslope from your normal. It can go up and it can go down, or it can even go down and go up and come back down. It can sort of sit on the spectrum, but mainly the general trend is that it goes down.
It's because it's a type of thyroiditis. So thyroiditis is when you have inflammation and damage of your thyroid gland, right? So initially when you get the damage, it releases the excess stored thyroid hormone, which causes hyperthyroidism. But then because you're damaging it more and more, you eventually run out of your stores and you're not producing as much. And that's when they become hypothyroid. So that would be the reason why. No problem.
Okay. And then the last main cause is mainly iodine deficiency. So you imagine if you don't have enough iodine, you're not getting enough T3 and T4 being produced because you can't iodinate your thyroid globulin molecules. And if you're not getting enough T3 and T4, then you're going to get hyperthyroidism because you're going to have low amounts of those molecules. And that's going to cause your TSH levels to go higher. And that's going to be a main cause of your goiter. So goiters generally can be associated with high levels of TSH. It's not a perfect rule, but it's a good rule of thumb to have in mind. Okay, so pathogenesis of Hashimoto's. So we talked about it a little before, but it's basically you've got your autoimmune antibodies which destroy your thyroid globulin, and it begins with that thyroiditis. It's like it's inflammation, and then it'll eventually progress to necrosis of the thyroid gland. And we've talked about that negative feedback. The signs and symptoms are pretty much the opposite of hyperthyroidism. So because you're not burning off your carbs and all your fats and proteins, a lot of the food you're eating is just going to be sitting in your body, so you get your weight gain. You've got your cold intolerance because your body isn't producing that heat from your basal metabolic rate. So body's sitting at like a lower baseline level of cold. So when the temperature changes like a little bit colder, when it goes down a little bit, you're a lot more intolerant to that change in temperature. Lethargy and depression, I just imagine that's just because your mentation and things are being slowed. And then you've got your sympathetic effects. So you've got your bradycardia, your muscle weakness, and your slow tendon reflexes because you've got reduced synaptic transmission across the NMJ.
So we have a question
Yeah.
that goes, if iodine deficiency causes hypothyroidism, why is it given as a treatment option for hyperthyroidism?
So we'll touch on that a little bit later, but basically if it's in large pharmacological amounts, it can have sort of this inhibitory effect, which isn't fully understood. But if it's a low level iodine, it's not going to be giving enough. It's not going to be supplying enough for the thyroglobulin molecules. But if it's a high amount, it has if it's a large dose of iodine, you can suppress T3 and T4 production. But that's not a sort of a permanent solution. It's more of sort of a temporary solution before people have surgery and things like that. But it depends on the dosage.
It's called the Wolff-Chaikoff effect. It was in the diagram before. It's essentially like it will temporarily suppress the thyroid hormone release, and it's just used as like a temporary measure, like pre-surgery or things like that. But it's definitely not a long-term treatment for hyperthyroidism.
Is that it?
Yep.
Okay.
So,
yeah. So we've got our goiter, our constipation because things are slowing down, and then our menorrhagia, as opposed to our amenorrhea from before. It's interesting because, like we said with before, how we're talking about things can go. You can start with hyperthyroidism and Hashimoto's and move to hyperthyroidism. Similarly, you can get amenorrhea and then move to menorrhagia. So amenorrhea doesn't always mean, menorrhagia and amenorrhea aren't always the best clinical signs for hyperthyroidism and hyperthyroidism. Yeah, fun fact or whatever if you care. Okay, and then we've got our simple non-toxic goiter. So this is when we've got hypertrophy of our thyroid gland, but we haven't actually got any changes in our T3 or T4 levels. That's why it's called non-toxic, because it's not really having an effect. But we've still got our goiter, and that's thought to be due to increased TSH levels. But there's no real consequence of that. It's just we've got this kind of big fat lump in your neck. Okay, so how do we diagnose our thyroid disorders? The first line level test is always our TSH. It's a lot more cheaper and it's a lot more effective in, it's got a high level of specificity and sensitivity for thyroid disorders. Only if their TSH levels are abnormal or deranged, then we do our second line T3 and T4 test, because they are a little bit more expensive and they're not always as necessary. If we're thinking that it's more of an anatomical sort of diagnosis that we need to make, so if we've got cancers, if we've got nodules, if we've got cysts, then we use our ultrasound, and we can use this thing called thyroid scintigraphy. So that's where we sort of apply our radioactive iodine, and we see which parts of the thyroid, which nodules are absorbing this radioactive iodine most. If there's really sort of overactive nodules in the thyroid, then they'll be detected as like hot because they're absorbing a lot of the iodine, and if they're not, then they'll be cold nodules. But that's not too important. It's mainly just important to know that your first line test is TSH, because that's always a common exam question. People always think T4 and T3, but no. Okay. Treatment. So we'll start with treatment of hyperthyroidism. So we've got a bunch of different drugs that we use. So we've got Carbimazole, so that's sort of our long-term pharmacological treatment, our anti-thyroid drug. Our beta-antagonists are mainly for symptomatic relief to treat all our sympathetic symptoms. We've got iodine if we've got a pre-surgical treatment, or even if we're waiting for some of our other drugs to kick in. We've got radioiodine, which is kind of a newer sort of therapy, and thyroidectomy as removal of the entire thyroid if there's sort of refractory hyperthyroidism, or we just can't treat it, or even if it's causing anatomical like compression on our nerves or trachea or esophagus. So we'll talk about one by one. Carbimazole, so it's a thionamide, that's its class. So the mechanism of action is going to prevent our iodination of our tyrosine on the thyroglobulin molecules. It's got another secondary function on thyroid peroxidase. So if that's inhibiting the thyroid hormone function, a thyroid hormone function production, it's going to be also inhibiting it in another way. But that's not as important. The main one to know is it's inhibiting the iodination of tyrosine. And that will result in a lower level of T3 and T4 circulating through our system. But it's important to know it's not an immediate effect. And that's mainly because we've got a lot of our T3 and T4 already stored up in our thyroglobulin. So those will already be stored and ready to go for another like 2 to 3 months. So we need to wait for this carbimazole to take action on our T3 and T4 before we see an actual effect in our circulating amounts of T3 and T4. So there's a few different indications for its use: short-term use before surgery, or prolonged use mainly in Graves' disease and also other hyperthyroid disease. The main adverse effects, we've always got our like headache, nausea, rashes, allergies, arthralgia. Those are pretty like unimportant. The main ones are congenital hyperthyroidism. So if someone's pregnant, our carbimazole thionamides can cross our placenta. They can cross into the placenta and affect the developing fetus. And because they're going to be reducing iodination, they're going to be reducing the amount of T3 and T4 in the developing fetus, and that's going to cause that cretinism because they're not going to have enough T3 and T4 to support adequate development and adequate in utero growth, basically. And the other one is agranulocytosis. So that's when you have a reduced number of granulocytes and neutrophils, and that's just going to increase your sort of immune susceptibility to infection, all those kinds of things, TB, all that sort of stuff. But those are the main adverse effects to know. Contraindications are in pregnancy because it will cause congenital hyperthyroidism, possibly cretinism. Okay, beta antagonists. So there's a couple different beta antagonists you can use. You can use propranolol or atenolol. Propranolol is non-cardioselective, so it's going to affect all our beta receptors. It's going to work on our cardiac symptoms as well as our tremor. But our atenolol is only going to be working on our cardiac symptoms, so our tremor is going to be unaffected. That's because we've only got our beta-1 receptors in the heart. There's no beta-2 receptors in the heart. And so if we block all those, our beta-1 receptors, we're going to relieve our tachycardia, angina. And then if we block our beta-2 receptors, we're going to relieve our tremor and agitation. And these are generally used when we're waiting for like our anti-thyroid drugs to take effect. So as we said before, our carbimazole it takes about 4 to 8 weeks to actually kick into action. So in between that time, we can't just let the person sit on their symptoms and like live their life in agony or whatever. So we've got to give them some sort of treatment. So we use beta agonists as sort of our antagonists as our sort of bridging drug. If people are going through a hyperthyroid crisis, so that's when there's like a acute sort of exacerbation of their hyperthyroidism, we can also use beta antagonists as a short-term treatment for that until it passes, or we can use it prior to surgery as, again, sort of symptomatic relief before we're actually going to fix the cause of their problem. Okay, iodine, so this is what we were talking about before. If we give them large pharmacological amounts, so not like small dose, we give them like a heavy dose of iodine, we can cause this temporary inhibition of thyroid hormone synthesis. And that it's a pretty short-term use. So mainly, again, it's used before surgery if we need to relieve symptoms. But it only works for about 10 to 14 days. Beyond that, it doesn't have much efficacy. Adverse effects, allergic reactions as always. If people have got a toxic nodular goiter hyperthyroidism, it actually might worsen it, but it's uncommon. And again, contraindications in pregnancy and breastfeeding, because again, it can cross the placenta, it can be transmitted through lactation in the milk, and can have adverse effects on babies in that aspect. Radioiodine. So this is mainly if we've got cancer. So what we do is we emit sort of these beta particles which have a local cytotoxic effect, and they're going to kill our thyroid cells. The reason why we use it is because they only work on our thyroid cells, because only our thyroid gland is the only structure which really takes in iodine. So it's the only one that's going to be taking these beta particles of radioiodine. And so it can be quite a good treatment. It's very selective, localized, and specific. We use it in thyroid carcinoma, but our adverse effect, if we kill off too many cells, then we can get hypothyroidism. It can actually cause more cancer based on its radioactive properties. Yeah. And again, pregnancy and childhood contraindications, not good to use it in pregnancy. You can affect your fetus no matter how distant it is. And childhood, it's always never really a good idea to use radiation in really young people because you don't want to increase their lifetime risk of cancer. Propylthiouracil. So this isn't really a core drug, but I thought I might put it because it's pretty important. But again, it's gonna be sort of used for treatment in our hyperthyroidism, and it's gonna inhibit our peripheral conversion. Because imagine a lot of our T3 is coming from our T4, so we're inhibiting the conversion of that. We're going to be inhibiting a lot of the, or at least reducing a lot of the impacts of our thyroid hormones. And we mainly use it because when carbimazole is contraindicated, because it doesn't cross the placenta. And that's probably the main two important points to know. But yeah, it's not core, so I don't expect that they'll examine you on it, but it might just be like a extra option or multiple choice. So I thought I might put it in there. Okay, and then our sort of last resort treatment is thyroidectomy. And that's where we just remove the thyroid gland if there's too much, if there's refractory disease or if there's anatomical structures being affected. So we'll just remove the thyroid gland. But that's, yeah, kind of our last option, really. Surgical options are usually the last option. Okay, and then how do we treat our hypothyroidism? So we've got an absence of our thyroid hormones. We need to pretty much just replace them. And so we give them thyroxine, which is a hormonal replacement for our thyroid hormones. So it mimics the effects of T4. It's an oral drug. Takes effect mainly after 10 days. That's when it's peak effect. The adverse effects and indications aren't super important, but it's important to note that if you've got a child with congenital hypothyroidism or cretinism, you can actually, if you tackle it early enough, if you replace their hormones early enough with thyroxine, you can reverse that cretinism. You can let them live a normal life, and that's like really good for their morbidity, mortality, all sorts of things. It's just like a happy ending. If you're able to like save their life and like give them good quality of life, it's great. Adverse effects, I wouldn't say are great, important to know, but again, you can if you give them too much thyroxine, you can trigger hypothyroidism if you're overdosing them. And it's especially important with Hashimoto's because it's often a progressive disease, so you often have to like modulate the level of thyroxine that you're giving them. Because as their thyroid function is slowly decreasing, you'll need to up the thyroxine dosage, which can be hard for GPs who don't really care about the math or whatever. So that's why they often refer them to like specialist endocrinologists and stuff like that. Another option for people who have hypothyroidism, some of them just get their entire thyroid glands removed, so they don't have to deal with the struggles of dosage and like dealing with those risks of hyperthyroidism and things like that. They might just get like a prophylactic thyroidectomy because you can live without your thyroid. You just need to be maintaining and taking your medications regularly, pretty much. Okay, so now we're on to thyroid exam and thyroid history. So a lot of these symptoms we talked about before, but I think a good way to think about it is going from head to toe. So I start again with like mental state. So in hypothyroidism, you're going to agitated, whereas in hypo, they're going to be slowed. Heart rate, they're going to have fast heart rate in hypothyroidism and slow in hypothyroidism. Appetite changes is going to be increased because they're really hungry in hypothyroidism. They want to get as much energy as possible, whereas in hypothyroidism, it's the opposite. It's going to be decreased appetite. Weight changes, it's going to be weight loss in hypothyroidism because they're going to be burning off all the calories, burning off their fat, protein, all those sorts of things. But in hypothyroidism, because they're not burning it off, they're going to get fatter quicker. Changes in bowel movements, so hypothyroidism mainly affected with diarrhea because things are moving a lot faster through the gastrointestinal system. Hypothyroidism opposite because you've got constipation. Menstruation changes, oligomenorrhea and amenorrhea in hypothyroidism, menorrhagia in hypo, which is the odder one. Skin changes are going to be sweating a lot because you've got your sympathetic response going on in hypothyroidism. And opposite in hypothyroidism, you're going to have dry skin and even alopecia as well, so hair loss in various parts of the body. And then hypothyroidism, you're going to get intolerance to heat, not hot, and hypothyroidism will be intolerance to cold. And then there's your other sort of odd ones that don't really fit in. So palpitations in hypothyroidism mainly to do with your increased heart rate and increased sort of contractility of the heart. Hypothyroidism, you're going to get chest pain because Actually, I'm not actually too sure about the chest pain, why it's causing chest pain, but I imagine it'll be something to do with decreased supply to the coronary vessels. I guess if you're having bradycardia, you're not getting as much cardiac output to your coronary vessels, and so you're getting this mismatch in demand and supply, and that's going to trigger pain. Carpal tunnel is mainly to do with deposition of fluids and inflammation there. So you're going to get deposition of fluids within the carpal tunnel, and then you're going to get carpal tunnel syndrome and cramping of muscles. Okay, so this is like a good diagram I use just to think about the questions I need to ask. So again, head to toe, so mental condition, heart rate, appetite and weight, your bowel function, menstruation, and then skin and heat finally. Yeah. Okay, thyroid examination. So a thyroid exam is very examinable, I think. I think we had a thyroid exam. I can't remember if it was hypo, or both. But they can often ask you to do either one. They can ask you to do both together. So you really got to be prepared for this one, knowing the symptoms for either or how to do them in combination. So you start off by looking at their clothing for both. That's looking at their tolerance to the heat, their mental state and mood, and body habits. So whether they've got weight gain or weight loss, whether they're effective or not. And frightened faces and hypothyroidism, if they've got that sympathetic response going on, or if they're in hypothyroidism, if they've got that slowed response going on. They might also have hoarseness of voice due to recurrent laryngeal nerve palsies and deafness. After that, you'll do your vitals. So you'll either be looking for tachycardia or bradycardia. Those are really the main ones you need to be looking for. The others aren't as important. Yeah. In terms of peripheral inspection, there's a few other stuff to be aware of. So onycholysis, tremor, palmar erythema, warm steady skin, and proximal muscle weakness and brisk reflexes. So proximal muscle weakness, that can be assessed in either the arms or the legs. It depends on really what you like to do. And likewise with brisk reflexes, whatever you're feeling like. If you want to do ankle, biceps, knee reflex, they're all pretty relevant. They can all assess for brisk reflexes. Hyperthyroidism, you're going to be looking for cool, dry skin, skin discoloration, yellow or blue, whether they're jaundiced or cyanotic. If you've got anemia, carpal tunnel syndrome, so you'll check for wasting of the thin amines, so you do Tinel's or Phelan's test. And if you've got slow reflexes, all to do with sort of slowing and like reduced peripheral perfusion, things like that. Face and eyes.
Also,
yeah.
Just with the tremor, you're looking for a fine tremor, not so much a coarse tremor. So you might not see it like when they just hold their hands out, but the test is that you put a sheet of paper over the top, and then you can see like the tremor a lot clearer in the sheet of paper. There's also a question here: why do you get proximal muscle weakness in hyperthyroidism?
So I think it's something to do. I looked it up as well because I wasn't sure. It's something to do with degeneration of the muscle fibers at the neuro NMJs, basically.
I think it's that imbalance between the protein synthesis and the protein degradation. So in hypothyroidism, because you've got that super high basal metabolic rate, you're essentially going to be breaking down all your other alternative energy sources, including fats and proteins. So you get generalized muscle wasting, and that will be most prominent in the proximal areas first.
Yeah, that makes sense. Okay. Face and eyes. So face and eyes is pretty. Is there another question?
No, that was just a thanks.
Okay. I feel like the notification problem. Okay. So face and eyes, you're going to be again looking for warm and sweaty skin or cool and dry skin. Skin discoloration, similar to as before when we're looking in the hands. For face and eyes in hyperthyroidism, you're going to be looking for a lot of the signs of Graves. So exophthalmos, proptosis. You're going to be looking for chemosis, conjunctivitis, corneal ulcerations if they're keeping their eyes open too much, or if they've got ophthalmoplegia, which is basically paralysis of their eye movements, basically of their eye muscles. So you'll learn this later. Actually, I don't know if you guys have done it, but you do like H movements to like track their eye movement and see like if there's any problems with their eye movements. You'll check the thyroid stare. So if they've got like this very prominent gaze that they're like holding their stare. It's very, I don't know how to describe it actually. It's very ominous and like confronting kind of stare. Lid retraction. So if their upper eyelids pulled back a lot, I think it's best to look at pictures for this online. But if their upper eyelid is pulled back a lot in comparison to one of their other eyelids, that's a sign of hyperthyroidism. And if they got lid lag, so if you're doing your H movements and they're moving their eyes, but their eyelids aren't moving at the same pace if they're not synchronous with their eye movement, particularly when they move their eyes down, that's lid lag basically. Hyperthyroidism, you've got a few other ones. They're not kind of wishy-washy, but like know them, just reel them off. Thickened skin, periorbital edema, xanthelasma, and tongue swelling. Hyperthyroidism, hypothyroidism, most of them are associated with increased fluid retention. So you can get like flow murmurs, congestive heart failure, pericardial effusion, or pleural effusions. Usually you won't really have time to be listening for everything in the actual exam. So either they'll say not to look for it, or you'll start doing it and they'll like be like, okay, move on. Happy with that. But you've got to be looking for signs of those. And then in their legs are also pretty important. So again, you can do your reflexes. You can check for proximal muscle weakness. And then there's two important ones. So pretibial myxedema and hyperthyroidism, they get this like, it can also be called brawny myxedema, but they get this rash over their shin bones. It's like a reddy, almost, it can be browny, but like more reddy dermatitic rash over their shin bone. And then hypothyroidism, they can get non-pitting edema. So they get that fluid retention. And when you press down, you don't see their, when you press down on the effusion in their legs, you're not going to be seeing any pitting. You're not going to be seeing those finger marks being retained. And you can also just like remove their socks and see like if there's going to be a mark there left by the socks or not. But it's important to like press against bone to actually check if it's pitting or non-pitting. Yeah.
And with the thyroidism exam, specifically the hyperthyroidism exam, they really like to assess which signs are specific or unique to Graves. So within the hyperthyroidism exam, all of the eye signs, the pretibial myxedema, and the clubbing, they're specifically associated with Graves, whereas the other ones you'll see in other generic types of hyperthyroidism as well. And if you want to be fancy, clubbing in the thyroid exam is called thyroid acropatchy. It's just like specific context, but it's basically just clubbing.
Nice. Okay. And then we move to our neck. So we'll start with our cervical lymph nodes, looking for any cancers that have been metastasized. We'll check for trachea, deviation in tracheal tug, for any anatomical dysfunction there. And then we'll move more closely to inspection. So we're going to be looking for a goiter, any masses. We're going to perform Pemberton signs. So we're going to ask them to raise their hands above their neck, looking for any obstruction, SVC obstruction, any dilated veins in the neck, any redness in the neck. We're going to be looking for any necklace scars. So that's indicative of a previous thyroidectomy or thyroid surgery in general. And they're going to ask them to drink some water. We're going to see if there's any masses that move. And then we're going to ask them to stick their tongue out after, because we'll also see if the thyroglossal cyst has either ascended into the tongue where the foramen cecum was, or whether it's still moving, because it's still attached. That thyroglossal cyst will still be attached by the thyroglossal duct in the neck, and you can still see the cyst move in the neck as well. Yeah, so if you see like a cup of water or something, just be like wary that like you're gonna actually have to do that. So like keep an eye out in your OSCEs or whatever. Next, you move to palpation. So it's important to do palpation from behind and in front. They love that. Get you some good marks. But yeah, you'll start by palpating your thyroid cartilage, and you move down, feeling the borders of the thyroid cartilage, pretending like you feel it, pretending like you feel the difference between the cricoid cartilage, and feeling the lobes of the thyroid. I'm checking for size, shape, its normal consistency. Is there any tenderness? Are you in any pain? And is there any mobility? And then I can feel the joint in the midline being the isthmus. And then you'll do all of that from in front. You move to percussion, so percussing over the manubrium. It's direct percussion rather than with your other hand. So you just need to tap over your manubrium with one finger to check for any retrosternal goiter. So if there's a retrosternal goiter, you'll hear a dull sound. The goiter has descended into that area and causing that dullness. And then you'll auscultate over the lobes of the thyroid, listening for any thyroid grues. And that's if you've got, that's also pathognomonic for Graves, because you'll get like this proliferation of the thyroid gland and like heavy proliferation of your blood supply, and that'll cause turbulence in the vessels, causing your bruise. And that's the end of the thyroid exam. Any questions? Nope.
Doesn't look like it.
Okay. We'll move on. I'll stop sharing.
And I'll share mine, yeah. Cool. Can you guys see my screen?
Yeah.
Cool. All right, so if there were no questions for Gavin stuff, we'll move on to the parathyroid. So the parathyroid is one of the hormones responsible for calcium, but we'll also touch on all the other stuff related to calcium and just calcium in general. So I guess this section could be called parathyroid, but parathyroid / calcium and your calcium metabolism or calcium homeostasis sort of stuff. So let's talk about calcium. So calcium, 50% of your calcium is free, meaning the part in your blood, the amount of calcium in your blood, half of it is free, meaning it's not bound to proteins or complex ions. And this is actually quite a large proportion, especially when you compare it to the thyroid, which is at 0.5%, as Gavin talked about earlier, and steroids, which are at 5% bound. Also, if I start like cutting out, let me know, just so like I know my internet's going to terrible. Most of your calcium will absorb through your intestine, but not all the calcium that passes through your intestine will be absorbed. And this is controlled by your PTH, your calcitonin, and all that kind of stuff, which we'll talk about in a second or later, really. When the bones have a lot of calcium stored in them. So realistically speaking, you have a very large calcium store. And with enough calcium, your bone will naturally form, but also naturally degrade as it kind of like goes through recycling. But in pathology, such as osteoporosis, that process is kind of flawed, and we'll talk about that later as well. Your calcium and your phosphate are also linked in this stage. So your calcium regulation, how that's related, is linked to your phosphate regulation because of the relation with bone. And this is something we talk about when we're looking at the kidneys. When your phosphate is really high or your calcium is really high, that can kind of play a problem. Your kidneys also reabsorb calcium and can change how much is excreted, and that's also controlled by the hormones we'll be talking about later. But that's just an overview into what calcium is. So this is kind of the regulation. It's an interesting diagram, I guess, but frankly, the most important thing is just a lot of it's absorbed and put it into kind of the extracellular fluid, and a lot of it can come from the bone as well, but normally in constant flux. So the role of calcium, the two most important ones are neurotransmission and muscle contraction. In particular, the cardiac and larynx muscle contractions. And this particularly is what makes calcium or low calcium or hypocalcemia lethal, in that your heart won't contract or your larynx will seize and you can't breathe, which is problematic to say the least. Obviously, it's also related with bone strength and teeth, but it also has all other factors such as blood coagulation, which is also important. The four main hormones we'll talk about are parathyroid hormone, PTH, vitamin D, and calcitonin. There's also a fourth hormone called parathyroid hormone-related peptide, but this is mostly from tumor cells. But we'll touch on that as well in a sec. So what is the parathyroid hormone? So this is located posterior to the thyroid gland. It's normally a set of 4. It can be 2 to 8, but normally it's like a set of 4, as you can see in this diagram. Anything apart from that in terms of the anatomy in front of you, I don't think is that important. There's an embryological aspect, which we'll learn next semester with the fact that these actually start higher than these ones, but that's not really that important for you guys right now. There are, histologically speaking, there are 2 types of cells, but only realistically one that you need to know about. So chief cells, these are the ones that predominate in the parathyroid gland. And these are clusters. So clusters meaning like these kind of little clusters around here. They're kind of hard to see in this picture, but they are clusters that produce PTH. The other group of cells are called oxyphil cells. And I think the real important thing to know about those is that they exist, and that's it. So if you ever get a multi-choice asking, or with an answer, particularly about oxyphil cells, then I don't think it's going to be the correct answer, but it's just a random cell that's in the parathyroid gland. And these arrows apparently point to some of them, but that doesn't really matter. The parathyroid is also very well vascularized, as are all your endocrine tissues. So your thyroid, as Gavin was talking about earlier, and as well as your pancreas and that kind of stuff. And it's supplied from the inferior thyroid arteries. So these ones coming up here. The parathyroid hormone is a polypeptide hormone, and importantly, it's a calcium-raising hormone, and will respond when calcium falls below 2.5 millimoles per liter. But that's not really an important figure. Basically, all you're saying is a negative feedback loop where low calcium will trigger PTH, which will cause calcium to re-rise. PTH itself starts as a pre-pro PTH, which is then cleared by the endoplasmic reticulum and the Golgi body. That's all that's kind of important there. And these will be metabolized either in the target cell or cleared by the liver or kidneys. So if you have problems with those, then you might have problems with your liver or with your PTH clearance. Normally, PTH release is slow, but it can be accelerated through calcium, as detected by the G protein coupled calcium receptor. Your vitamin D will also inhibit PTH synthesis, which I think is kind of something that you don't really think of, but vitamin D is actually inhibitory to PTH synthesis rather than activating it or anything like that. So your effects of parathyroid hormone. So the primary two things it affects is your bones and your kidneys. Okay, so in your bones, it increases your calcium to release and bone resorption. But it doesn't do that by binding to osteoclasts, but rather it binds to your osteoblasts, which are normally the cells that kind of produce bone rather than the ones who kind of destroy bone to begin with. But it's by binding to the osteoblasts, which indirectly activates the osteoclasts, because the PTH will bind to rank ligand and decrease the osteoprotegerin synthesis. Osteoprotegerin, just think of it as like protecting your bone. So normally this stuff inhibits, I guess, osteoclasts from working, but here now you're using the PTH to block that pathway, as I can talk about here. This will also cause phosphate to be released, as bone also has phosphate binding to the calcium, causing phosphate ions to release in your body as well. Your estrogen and androgens will also increase bone formation, and this is kind of why in menopause, when your estrogen levels fall, osteoporosis will occur. And we'll talk about this a little bit later in terms of how that specifically works, but it works in a very similar way with the rank ligand and that kind of stuff. Your glucocorticoids will also increase bone resorption, which will lead to osteoporosis, and this is kind of the cause, I guess, of Cushing's disease and Cushing's syndrome, causing you to have osteoporosis in the end as well. In your kidneys, your PTH will also increase calcium reabsorption, but this time it has no effect on phosphate reabsorption, which is a critical difference. And so it increases your plasma calcium, but not your plasma phosphate. It also activates your vitamin D. So vitamin D never really, it gets secreted or made or consumed, I guess, as a pre-hydroxylated form. Your PTH will activate this to occur in the kidneys. And it also then causes the increase of absorption of calcium in the gut. Cool. So this is a good diagram, I think, for that whole process. So your PTH will activate your kidneys to increase calcium absorption and decrease phosphate reabsorption. In your bones, it increases calcium, also increases phosphate release. This activating the kidney will cause you to have more vitamin D, causing you to have increased gut absorption of calcium. Now, vitamin D. So vitamin D is one of your fat-soluble vitamins. This is kind of important to remember with the ADEC group, I guess. And it's present in the diet, but can also be metabolized and manufactured in the skin. This is kind of why sunlight is kind of good, I guess, or one of reasons, I guess, why sunlight's good. It helps you make vitamin D. It needs to undergo many hydroxylations to become metabolically active, and this occurs in the kidney. What hydroxylations are, don't really need to know, but basically just like you tag on some hydrogens on it. But effectively it occurs in the kidney and it gets activated like that. It acts with parathyroid hormone to increase plasma calcium concentrations, and it's transported and plasma bound to proteins. and act as intracellular receptors. The curve is steeper than PTH, meaning the control over your vitamin D3 is much closer than it is your parathyroid hormone. Basically, it means it responds a lot quicker to a decrease in your plasma calcium concentrations than your parathyroid hormone will. That's effectively what it means by control. Your low vitamin D will also lead to rickets because of low calcium levels in your body. So the effects of vitamin D. So vitamin D has the same effect on the kidney, bones, and gut as well. So the same sort of targets we were talking about before. It also has an effect on the parathyroid gland as it increases. As it increases in vitamin D, it will cause a decrease in parathyroid hormone. That's kind of an important thing to talk about. So in kidneys, it will increase both calcium and phosphate reabsorption, which is different to parathyroid hormone, which only increase both calcium, but not phosphate. In the gut, it will increase both calcium and phosphate absorption. And in the bone, it will stimulate the differentiation of osteoblasts and rank ligand production, which will bind to osteoclasts, increasing the calcium and the phosphate you basically produce. So the bolded stuff is kind of the important things. The nitty-gritty in terms of how rank and that kind of stuff works is not the most important, but effectively is the methodology in which they work. Yeah. So this, apologies for all the random highlights, but this is kind of, again, another good diagram for it. So this is your vitamin D. It will increase your calcium phosphate reabsorption, and also stimulate your calcium and phosphate out of your bone. It also impacts on your parathyroid hormone to kind of reduce as a result of the production of that. Calcitonin and parathyroid hormone related protein are two different sort of hormones. So calcitonin is made by the parafollicular C cells, Gavin talked about in the thyroid. Effectively, what they do is the opposite of parathyroid hormones. They will increase in response to increasing in calcium and inhibit bone reabsorption and increase the urinary calcium and phosphate secretion, meaning more calcium, more phosphate will be excreted in urine. It's useful in conditions when there's increased bone turnover, and there's very little times when this is going to be a problem endogenously. Your parathyroid hormone-related polypeptide is either made in the placenta, or when it's in adulthood, is produced by tumors, and that's kind of the only reason that ever comes a role. And what it does is exactly the same as parathyroid hormone. So think back to what I talked about: parathyroid hormones, the bone, and the kidneys. It will do the exact same thing. It just comes from tumors instead. So this is a good summary of the overall picture, and I think this is kind of important to remember. So if you look at this kind of table, it's kind of almost the complete opposite of what parathyroid hormone does. So calcitonin, you can almost think of it as the antagonist or the other way to what the parathyroid hormone will do. All right, so hypercalcemia, hypocalcemia. So classically, the symptoms for hypercalcemia are moans, bones, stones, and groans. So your moans will come from your confusion, your inability to concentrate, lethargy, and drowsiness. Your bones will lead to complications in your bones, such as osteoporosis or pathological fractures due to like osteoporosis, basically, where you have weakened bones. Stones is a result of kidney stones, which can result in renal failure, as we talked about last time, if you get chronic renal kidney stones and no treatment for them. But also more classically leads to a lot of pain. Abdominal groans is constipation, loss of appetite, nausea, or vomiting, and it's related to the effect on smooth muscle. So if you get a clinical presentation where these four are, implicated, then you can think about your hypercalcemia, and think about how that might be related to your parathyroid hormone, in the fact that it might be elevated because it's producing too much of this calcium. The general issue with calcium levels is also that it balances sodium. A depolarization requires sodium to enter cells, whereby in high calcium, your calcium will block those sodium receptors randomly. And as a result, I guess it hyperpolarizes the cells, but doesn't basically allow that depolarization process to occur. Now, when you have hypocalcemia, you have the opposite problem. You have low calcium, so that endogenous kind of random blockade of the sodium receptors doesn't happen. And your sodium will just enter more frequently and more rapidly into kind of these muscle cells and like that. And this causes tetany because it increased action potentials. And this can affect your larynx as well as your nerves and your brain, causing seizures and breathing problems. And this is kind of why things such as hypocalcemia are life-threatening as well. So this is kind of a diagram to kind of illustrate that. So these are the signs of hypercalcemia as we kind of look through. But fundamentally, the moans, bones, stones, and groans are the kind of the four that are, I guess, the most important in the perspective of the clinical picture for a hypercalcemia patient. So osteoporosis. So osteoporosis is simply porous bone, and it comes from decreased bone mineral density. Importantly, it's degradation of mostly the trabecular structure. Normally in homeostasis, you get remodeling of bone, so the responses to mechanical pressures, basically. And normally it's in continual balance. But in osteoporosis, what occurs, you have an increase in resorption rather than deposition, which causes the osteoporosis to occur. Because the trabecular bone has more turnover than normal, you have an increased effect on those kind of bone areas. So the lower back, the hip, and the wrist, which is also the most likely places for fractures, are the places where this will have the most impact. These osteoporosis increases with age and increases effectively, especially in women after menopause. It's also true of men, but it's much less common. It's much more classic to be a woman who presents with these kind of problems. As a kind of add-on, if you have a clinical picture where someone has a kind of bone pain or back pain, sudden back pain, it's very also likely to be osteoporosis due to something called a compression fracture. And I forget if I talk about it later, but I'm going to talk about it now. In that, because of this weakening in the bone structure, in the trabecular structure, your bones almost just compressed together due to the weight of your body, causing sudden pain in the back of your back. So a woman who's old and gets sudden back pain, think osteoporosis. Any more questions? So your bone mineral density is kind of just a test to determine the density of your bones, and it's determined by genetic factors, endogenous factors, and exogenous factors. Effectively, once you're 32, your bone will slowly start to degrade as you just age. It peaks at the age of 32. So I guess we have that to look forward to. The consequences of osteoporosis is the one that I was talking about earlier, so minimal trauma fractures. So one of those being compression fractures, where you just suddenly have a fracture in the back as a result. Hip and wrist fractures are also quite common. So old people who fall are much more likely to get neck and femur fractures and wrist fractures. These neck and femur fractures are also problematic because you have increased stasis and increased risk of hospitalization, which therefore puts you at more higher risk of other problems that you get at hospital, such as pneumonias and like that. So you really don't want to kind of get a neck and femur fracture, especially as an old person. You also have reduced independence because if you can't walk around and that kind of stuff, you struggle a lot more. And you also associate with increased mortality due to your likely complications or more likely complications for when you get to hospital. However, it is a silent disease, as in before any of these things kind of happen, no one really knows you have osteoporosis. You can't tell you have osteoporosis, you don't get tired or anything like that. You just suddenly get a fracture from doing nothing at all. And then it's problems start to ensue. So it's problematic not only for detection of osteoporosis, but it's also problematic for treatment compliance, especially because some of these treatment options that we'll talk about later have some side effects and some detrimental complications that not everyone would love to have. Is there any way we can screen for it? So yes, you can screen for it with a bone mineral density score, which is going to talk about now. So the two major kind of factors are age and bone mineral density score for what your risk factors for osteoporosis are. And as such, you can kind of try and screen for your bone mineral density score. You can also do things with calcium and your phosphate, which I'll talk about, not phosphate, your calcium, your vitamin D, which I'll talk about later, but that doesn't have as much of an impact as we think or as we hope it would. So hopefully I can answer it in a second. If I don't answer it, then message it again and ask the question again. The bone mineral density score is a reading that's compared to a central value, and it's called a T-score. So the number of standard deviations away from a young adult mean of their sex. So I guess if it was a 60-year-old lady who's getting a bone mineral density score, they'd get a comparison from a 30-year-old lady who's healthy, basically. A Z-score is a standard deviations away from mean of someone of the same age and sex. So obviously that would be a bit lower because you have natural degradation of your bone. A T-score between 0 to 1 is considered healthy. Between 1 and 25 is osteopenic, and more than 2.5 is osteoporosis. So osteopenia is just lower bone. Osteoporosis is porous bone, basically. Other risk factors are previous minimal trauma fractures, because simply you are more likely to have it. Osteoporosis if you've had a previous history. Oral corticosteroid use, rheumatoid arthritis, and alcohol intake and current smoking, just purely because they recite everything. Osteoporosis prevention. So as prevention, what you can do is you can try and modify your risk factors in physical exercise. So physical weight-bearing exercise is good for bone development and bone growth. Your calcium uptake and supplement can be used if you have a lower, if your current intake is insufficient. And it reduces the rate of bone loss and fracture rates, but the vitamin D concentration needs to be considered there as well. And your vitamin D, you can consider increased sun exposure, and only then, if it's deficient, you can supplement for it.
I don't know if we had this question or someone wasn't watching, but like someone said, is there any way they can screen for it?
Yeah, so hopefully I've answered that in the slide beforehand, but the real way to screen for it is the bone mineral density scan, which you kind of give people if you have a suspicion that they might have osteoporosis. If, for instance, they may have had a metatarsus fracture in the past, or they have a family history of something like that. Does that hopefully answer the question? I hope.
Minimal trauma factors are often diagnostic of osteoporosis.
Yeah.
Anyway, so yeah.
Yeah. If you suddenly fall over and you like break your wrist, it's kind of like a bit weird. And we get suspicious. All right. So before treating for osteoporosis, you have to exclude other diseases that could cause that bone fragility, such as your hypogonadism or your hyperthyroidism, which Gavin saw before, and manage the risk factors that can cause it, and recommend moderate exercise and consider fall prevention strategies. Because whilst we have treatments for it, they have side effects, and you kind of don't want to give medication unless you kind of have to. So always consider your non-pharmacological approach, as we've kind of talked about before. You also consider treatment if there's a presence of an osteoporotic fracture, so your minimal trauma fractures, or if the T-score is over 2.5. And there are two classes of osteoporotic drugs. So anti-resorptive, so inhibits bone resorption, and your bone anabolic agents, so stimulating bone formation. As I said earlier, because it's a silent disease, people aren't very good at compliance with these drugs. And that's bad because then these drugs don't really work. And so a lot of doctoring needs to take place to kind of convince them to take it and make sure they do it. Let's get into the medications. Firstly, hormone therapies, actually. So hormone replacement therapies. So estrogen directly inhibits bone loss by decreasing rank ligand and increasing OPGs, osteoprotein. And this is why normally when you have premenopausal women don't have as much problems with osteoporosis. But once you hit menopause and your estrogen levels fall, this inhibitory process fails. And as such, your risk for diseases increases. Now, by giving hormone replacement, you can re-establish that kind of indirect sort of inhibition. But what also happens is you have an increased risk of breast cancer and cardiovascular disorders due to kind of a lot of cancers, breast cancers having estrogen receptors driven as a result. As such, it's only really used for a short period of time, unless for 5 years, especially for those, and it's not less than 5 years, and for people without cardiovascular risk factors or a family history of breast cancer, because otherwise it's too big of a risk. Because we know that hormone replacement therapies are kind of good for them, people, there's also a second drug, which I think is a bit more new, called selective estrogen receptor modulators, or otherwise known as SERMs. Your example here is aloxafen. But effectively, they try to do the exact same thing, but more try to target the bone rather than the other organs, I guess. It's kind of good in terms of the fact that it does target the bone, not the breast and endometrial tissue, causing your breast and cervical cancers. But it still retains its cardiovascular risk. So that is kind of the problem with these kind of hormonal replacement therapies. Your big drug that you need to know for osteoporosis is your bisphosphonates, and specifically it's your alendronate. This is first line for postmenopausal osteoporosis and is a pyrophosphate analog. That doesn't really matter. But how it works is it's concentrated in your bone and incorporated into your mineral matrix. So basically it gets mixed in with the bone kind of layers and will inhibit your formation activity of osteoclast that is released. As your osteoclasts try to do its thing, it gets kind of exposed out as it kind of is mixed in with the bone to begin with. and it breaks open and therefore inhibits the osteoclast that is kind of around. This will increase bone mineral density and decrease your fractures, which is great. Alendronate is given weekly, but has poor oral bioavailability and decreased further with food. And so therefore you have to be really careful with informing people about what they eat and how they eat. So your first dose should be taken early morning and half an hour before food. And tablets should be swallowed with glasses of water. The patient needs to stay upright for 30 minutes to 1 hour because of esophageal and gastric irritation. And these figures are quite important because I think they assess these and they also give these as your clue for kind of why you need to take or what you need to tell patients for your bisphosphonates or kind of the symptoms or things they've been told to give you a guide in terms of what drug they're on. So this is really important in terms of your bisphosphonates and specifically alendronate. In terms of kind of what their side effects are, so as I said, about esophageal and gastric irritation. New ones will be better, but frankly, they still do it. These benefits will last 12 months, and you're recommended to undergo a drug holiday after 1 to 3 years after 5 years of treatment. So you have 5 years on, then 1 to 3 years off. And that's to kind of try and prevent some of these negative adverse effects that are much, much worse. So you can get things such as osteonecrosis of the jaw. If you want, you can Google that. It's not very pretty. Or you get atypical subtrochanteric fractures, which are kind of these like very strange fractures that are on the kind of femur shaft. And it's apparently associated with anterolateral right pain and cortical thickening before with long-term use. So this drug holiday is the aim to kind of reduce these effects without massively impacting the beneficial effects it has on osteoporosis. Your other drugs include denosumab. So this is an antibody against rank ligand, which again decreases number and function of osteoclasts. Effectively, all it does is it does what OPG will normally do, which looks like rank, and basically will bind to these rank ligands and effectively negative neutralize it. And it's used if you can't use bisphosphonates. They increase bone mineral density, decrease bone resorption. The problem is that it's much more expensive and it's given as a subcutaneous injection every 6 months. Effectively, just know it's a monoclonal antibody and it acts to stop the activation of osteoclasts as by blocking rank ligand. And then parathyroid and parathyroid hormone fragments. So this is an anabolic effect. So the drug example is teriparatide. And at low doses, it helps with bone anabolism due to the stimulation of osteoblast development activity, which is actually quite different to what it normally does. So remember, PTH normally in large enough concentrations will go against that and cause bone resorption. But these low enough fragments and low enough quantities, it can have a beneficial effect in terms of bone development. It also increases your bone density and it decreases your vertebral fractures. There is a higher risk of fractures. It's used when there's a high risk of fractures and when other treatments are suitable, but there is a suggestion that it might cause osteosarcomas. These are sort of rarer, but the major idea is that it's an anabolic effect and it's a low dose. So even though it sounds counterintuitive, it's a working thing for osteoporosis. And what you can also do is sometimes you can also combine them together. So sometimes as a benefit, people can put those drugs together and have a go at using that. But remember the order is important. So teriparatide followed by denosumab showed benefit, but the other way around wasn't good. So these aren't really assessed that often, but if you wanted to know about this, your PTH fragments or your PTH analogs are used before the monoclonal antibody, and that has shown to be beneficial as well. But that concludes kind of what I had to say. So do we have any questions, any queries, any concerns about any of that? No?
Amazing.
If not, I will stop sharing and it's on video.
Sounds good. You see this?
Yep.
Yep.
Oh, it's loading, but yeah.
Can you see it now?
Yeah.
Okay, easy. Let's go through. So I'm going to be talking about the hypothalamic pituitary axis, and then essentially, because this controls quite a few things, we'll move on from this to growth and then to the adrenal gland. So you don't have to know much about the anatomy, but knowing where the hypothalamus is can be quite helpful. So it kind of just sits here. This is your brain stem. And then your thalamus kind of sits here, and that's kind of like a part of your CNS. And so the hypothalamus will sit underneath your thalamus there. And it's got a lot of functions, but essentially, if you remember that it basically controls homeostasis in your body, that's fine. This is the pituitary gland. So over here, the pituitary gland is right here. So it's under the hypothalamus. And this is the optic chiasm over here. And that's kind of part of the mechanism of how you see. So you need to know kind of the relations of the pituitary gland. And that's because things can compress it. And it's going to be the things that surround it that compress it. So above it, like before, you have the optic chiasm, and this is a coronal section, this picture. So you're looking kind of like either directly at someone or from the back of their head, and you've got X-ray vision. So you have the optic chiasm right above, and the pituitary stalk or the infundibulum, which is just it's kind of part of the pituitary. And that means that when you have a pituitary tumor, for example, you can compress the optic chiasm, I can do that, and that can cause visual field defects. Laterally, you have the cavernous sinuses over here, and that kind of drains some fluid in your head, and you'll learn more about this later, so I won't go into too much detail, but essentially in your cavernous sinuses, you have your internal carotid arteries, and your cranial nerves 3, 4, 6, and V1 and V2. And so you can get defects in these cranial nerves, which you will also learn about later. And inferiorly, it sits on the sella turcica of the sphenoid bone, which is a bone in your head, right over here. And then within the sphenoid bone, you have sphenoid sinuses, which are spaces. And this provides a location for surgical access. Essentially, they can come through the sinus and then access the pituitary gland there. You can also see that the pituitary gland has an anterior portion and a posterior portion, like this. And yeah, you've got the infundibulum kind of over there, and then you've got a couple nuclei in the hypothalamus which communicate with it. So the anterior pituitary is also called the adenohypophysis or pars distalis, and the posterior pituitary is also called the neurohypophysis or pars nervosa. And so you can kind of see them as two separate things, because with the embryology, the posterior pituitary comes from your ventral hypothalamus and your third ventricle. So these are all kind of part of your CNS, so it's neural tissue. What happens is it doesn't lose connection, it's coming from up there in your brain, and it comes down and it's dragged down without losing connection, so it's coming downwards. Whereas the anterior pituitary comes from Rathke's pouch, so that's kind of your oral ectoderm. So that's obviously not neural, that's more glandular. So that comes from below, because it's from your oral, and it goes upwards and loses contact. Sometimes during fetal life, there's also an intermediate lobe that becomes less distinct. The blood supply is pretty simple. You've got your hypophyseal arteries, so you've got your superior, which tends to supply your anterior pituitary, and then you've got your inferior and middle, which tends to supply your posterior pituitary. And then it just kind of drains out via your hypophyseal veins. And the good thing to know about that, well, the bad thing is it's very low pressure, so it's prone to ischemic insult. This is your histology. So again, it ties back into the fact that the anterior pituitary is glandular. So you can see that it's very cellular in its histology. You can see the acetophils, which are kind of like a light pink. And then you have your basophils, which are like a bright pink. And then you've got poorly stained chromophobes, which you don't really have to know about. And then your posterior pituitary, because it's neural, you can see that it's a lighter purple, and all the pale pink is kind of like your neurons and axons. And yeah, that's basically all you have to know. Yep. So how do they work? They both react to signals from your hypothalamus, but it's different in that the anterior pituitary reacts to hormones released by the hypothalamus into the capillary network. And then once it's got those hormones in the capillary network, then it generates its own hormones and then releases them via the hypophyseal veins. The posterior pituitary, because it's neural tissue, you have direct, synthesis of the hormones via the hypothalamus, and they just extend their axons down straight into the capillary network, and then it's released straight away. So your posterior pituitary hormones, there are only two. It's quite simple. So you've got your vasopressin or antidiuretic hormone. That's released from the paraventricular nucleus. So here, this one, in the hypothalamus. And I kind of remember that because like ventricular for vaso is a VNV and oxytocin for optics, oh no. And then what vasopressin does is, you've seen it before in the kidney, and in the kidneys it acts via V2 receptors to increase water reabsorption at the collecting duct, so you pee less, hence antidiuretic hormone. With V1 receptors, it attacks the smooth muscles and you get, or your vascular smooth muscles, and you get vasoconstriction. And it's controlled by your plasma osmolarity, which is quite sensitive, and your blood pressure. So your plasma osmolarity is detected kind of in the hypothalamus via your osmoreceptors, and your blood pressure is detected at your baroreceptors in the aortic arch and carotid bodies, and your low pressure, like volume receptors in your atria and pulmonary veins. Oxytocin is released from the supraoptic nucleus, and it targets the mammary glands for milk ejection. And it's part of the milk letdown reflex, and it's also involved in labor in the uterus. So its control is via the suckling stimulus, which are mechanical receptors in the breast, and stretch receptors in the cervix. Diabetes insipidus is when you have a vasopressin deficiency. So you don't get enough stimulation at V2 receptors, so you don't reabsorb enough water in the kidneys, and so you get poor water retention. And it also means, and essentially that means you become, quite dehydrated. And that causes large volumes of hypotonic and dilute urine. And because you're dehydrated, they get polydipsia. So they're very thirsty and they tend to drink lots of water. And usually you diagnose that by MRI imaging, and you'd see the presence of a tumor. The anterior pituitary is a little bit more complicated because the hormones produced locally, but it's still under hypothalamic control. And so the parvocellular neurons in the paraventricular nucleus, and so this is the same nucleus as your vasopressin one, they send axon terminals to the median eminence, and this releases the hormones into your vessels. And then the hormones in those vessels will trigger the anterior pituitary to release their own hormones. And there's this Harris hypothesis in which each anterior pituitary hormone has a specific hypothalamic stimulator and inhibitor. And there is a very distinctive pattern of feedback. And so you have your short loop feedback, which is essentially your anterior pituitary hormone, short looping straight back to the hypothalamus to decrease secretion of the first hormone that triggered it. Or what happens is the anterior pituitary hormone will cause secretion of another hormone by a third endocrine gland, for example, your adrenals, which will come back and then inhibit the anterior pituitary and the hypothalamus. And so that would be a long loop.
I think we just had a question from before asking whether males have oxytocin.
Yes, I think so.
Yeah, so I think males definitely have oxytocin. It doesn't quite do the exact same thing, but if it gets like ridiculously high as well, it can cause problems. But it doesn't like do the same thing in males. So it doesn't do much in males, I think.
Yeah, I would assume it could be a cause of lactation in males, but it's not important for you to know. The context in which you'd learn oxytocin this year would be mostly in repro, with regards to things like the letdown reflex and inducing labor.
Apparently has a role in moving sperm and production of testosterone, but minor. Yeah.
Yeah, it will be present in males though. Alrighty, these are the anterior pituitary hormones. This is basically as much as you need to know for some of them. We've already gone through like the thyroid hormone. So before it was stimulated by your TSH, which is released by your anterior pituitary, and that is stimulated by your TRH, or your thyrotropin releasing hormone, by the hypothalamus, and it's essentially secreted by thyrotropes. Lactotropes are the ones that secrete prolactin, which causes milk production and uterus contraction, kind of similar to oxytocin. And you'll learn more about these two during repro, so don't worry about them too much yet. Corticotropes secrete adrenocorticotropin, or ACTH, and that causes action on the adrenal cortex to secrete cortisol, which is your stress hormone. And that is activated by your CRH, or corticotropin releasing hormone, via the hypothalamus. And you can see that lots of these hypothalamic hormones are quite aptly named. So things like corticotropin releasing hormone, thyrotropin releasing hormone, or growth hormone releasing hormone is quite like intuitive. Gonadotropes will secrete FSH and LH, and that's involved in a lot of repro stuff again, which we will go through later, and it's stimulated by gonadotropin releasing hormone. So the next thing we'll go through is somatotropes and their hormone, which is the growth hormone, and it essentially causes growth. Pretty self-explanatory. There we go. So growth is the organized addition of new tissue that occurs normally in development from infancy to adulthood. They assess it to standardized growth curves. I wonder if I have one. I don't have one. But essentially, you can just look at their age, and then you can kind of see where they should be. And it's related to genetics. So parental height, and it's dependent on multiple hormones, which we'll go through a little bit later. You don't have to know this too much, but it's kind of good to know that your CNS is usually complete by 1 year. And then your bone, muscle, and fat divide until later in childhood. And then throughout your life, things like your GIT and your liver can retain the ability to divide. You tend to have your highest growth rates during fetal life, infancy, and puberty, which is pretty obvious. And then you have these 3 stages of growth. So you have stage 1 is in infancy, and the hormones involved are your thyroid hormone as well as growth hormone, and you have fast growth in all parts of your body. Stage 2 is school age, so you have your growth hormone involved in that, and that tends to be a slower growth of mainly your limbs. And then stage 3 is adolescence, so that involves your sex steroids, insulin, and growth hormone. And the main thing there is to know about adrenarche, which is when your adrenals increase their secretion of androgens. And that causes all sorts of developments, such as of the reproductive tract and your secondary sexual characteristics. These are your hormones involved in growth, so it's not just growth hormone. IGF-1 I'll go through a little bit quite soon, but obviously your growth hormone and IGF-1 are your major growth hormones. Insulin is involved, but it's mainly for energy, and it's also important in utero. And that's why insulin deficiency in childhood will be associated with growth retardation. Thyroid hormone is very important. It's both required for growth hormone action and requires growth hormone to have assert its effect. And that's why hypothyroidism before puberty will lead to growth retardation as well. It's also important for CNS growth. Cortisol inhibits growth, and that's basically all you have to know. And then your sex steroids, obviously involved in puberty. So growth hormone, it's a peptide hormone with 191 amino acids. You think you don't have to know these, but I think we actually had an example, like an exam question where they're like, how many amino acids in this hormone? So I put it in there. I wouldn't personally learn it. It's mainly transported freely, but it's 40% protein bound to growth hormone binding protein, GHBP. And this is its hypothalamic control. So you can see kind of the short loop here, straight from the growth hormone up to the hypothalamus to inhibit growth hormone releasing hormone, GHRH. But you also have the growth hormone going to the liver and some other tissues, forming IGF-1 or insulin-like growth factor 1, and then going all the way back in your long loop to inhibit the hypothalamus and the anterior pituitary. Growth hormone is released in a pulsatile manner, and they like kind of that word. It has a diurnal circadian rhythm, so its largest pulses are in the early hours of sleep. And things that increase its secretion are like sleep, exercise, stress and trauma, fasting, protein deficiency, amino acids and ghrelin. Decreased secretion are things like essentially your elevated IGF-1, which exerts its negative feedback, somatostatin, which is also a negative cause, and things like aging or elevated fatty acids. So it exerts its actions by direct and indirect actions. So it can directly affect things via growth hormone receptors. So that just means that the hormone itself travels in your blood, goes to its target organs, and then has these effects. And they tend to be anti-insulin actions. So if you remember what insulin does, it's the hormone that's released after your meals to make you store energy, right? So anti-insulin will be catabolic. And so these things, or these actions, are things like lipolysis, increased gluconeogenesis, and decreased glucose utilization. It also exerts indirect actions. So this occurs via insulin-like growth factors, or IGFs, such as IGF-1, but also some target tissues like bone. And so essentially your growth hormone goes to your blood, goes to your liver produces IGF-1, and then the IGF-1 then goes on to cause your insulin-like or anabolic effects, essentially growth. So things like protein synthesis, cartilage formation, bone growth. So all in all, what does the growth hormone do? It essentially makes you grow. It causes you to gain more protein. It causes you to lose fat. So growth issues. Excess growth, you need to know about these two conditions, just kind of generally. The main thing you need to know is acromegaly is excess growth hormone after puberty. And that means your long bones don't get longer, you don't get taller, but your other bones do. And that's why you get this kind of characteristic look. Gigantism is excess growth due to excess growth hormone before puberty. And so you get excess growth of the whole body, like this here. And so you do get taller. Laurent syndrome is when they have a mutated growth hormone receptor, so that cells can't produce IGF-1, and this leads to decreased growth. That's basically it. That's all you have to know. Well, onto the adrenal gland. Do we have any questions so far? Nope. Okay, we will move on. Greatio. So the adrenals are these guys, and they sit right on top of your kidneys. They're not actually part of your kidneys. And embedded in peripheral fat. So it's kind of like really quite connected to your kidneys. It lies close to the aorta and the vena cava, which means that surgery is risky. And it's supplied by 3 arteries. And it's pretty intuitive because a superior, middle, and inferior, and they literally come superiorly at the middle and inferiorly. So your superior suprarenal artery comes from your inferior phrenic artery. So that's your artery that's kind of just like on the underside of your diaphragm. And that makes sense because your diaphragm is above your kidneys. And then your middle suprarenal artery comes straight from the celiac trunk, right here. And then your inferior suprarenal arteries will come from your actual renal arteries. And that's one of the only branches of the renal artery. So that's also easy to remember. Adrenals have a vital role in the maintenance of pregnancy because it allows for maternal production of estrogens and also later on, the cortisol produced by the adrenal cortex is important for development of the baby, specifically the lungs. The adrenals are made up of your cortex, which is 90% of it, and your medulla. So you're kind of like the pituitary gland. You have different embryological origins, and that means that they do different things. So your cortex arises from mesodermal cells, and they produce your mineralocorticoids, glucocorticoids, and androgens. And on histology, you get the soft, foamy appearance with lipid droplets and lots of SER. Your adrenal medulla arises from neural crest cells, so it's more neural tissue. And they produce catecholamines, so your adrenaline and noradrenaline, which are part of your SNS, and they're composed of chromaffin cells. So yeah, modified neurons, essentially. And they look like that. I really like this diagram. This is essentially the summary of all the adrenal hormones. They're all steroids, and that means that they're all lipid soluble, which means that they can cross the membrane, go inside to the cytoplasm, and then affect the receptors there. So the receptor is going to be nuclear or cytosolic. And that also means because they're lipid soluble, they can't just be in your hydrophilic blood, and they're transported bound to carrier proteins. So you can see here that your cortex is like this outer bit and your medulla is this inner bit. And essentially you have the zona, well, your cortex has the zona glomerulosa, fasciculata, and reticularis. And the memory tool for that is GFR, like your glomerular filtration rate. And then the hormones released and kind of what they do, you can remember SSS, so salt, sugar, and sex. So your first one, your glomerulosa, will make your mineralocorticoids, such as aldosterone, and regulate like your salt, essentially. Your zona fasciculata, for GFR, will be involved in sugar, so that's your glucocorticoids, such as cortisol. And then your reticularis is involved in sex, so that's your androgens. And then your medulla, obviously your SNS, so your epinephrine and norepinephrine. Steroidogenesis is actually quite kind. You don't have to learn everything on here, but it's good to kind of learn in what order it is. So what they use is essentially they use cholesterol, and then the initial rate limiting step, which is quite important for you to remember, is its conversion to pregnenolone via star protein. And yeah, they'll often ask you about this. The pathway is from your mineralocorticoids to your glucocorticoids to your androgens, which is kind of convenient because it's the same as your GFR, it's the same as your salt, sugar, sex. So just remember that, and then remember that you have your 17 hydroxylase kind of cutting in between your mineralocorticoids and your glucocorticoids, and then you have your 21 hydroxylase cutting off essentially the end parts of your mineralocorticoids and your glucocorticoids. And what this means is they kind of ask you about these two deficiencies. So if you have a deficiency in 17 hydroxylase, then you cannot pass from pregnenolone to 17 alpha hydroxylase pregnenolone. And so you're blocked off between the mineralocorticoids and the glucocorticoids, which means you get decrease in cortisol, which then causes a reflex increase in ACTH, because that's what's usually causing, well, triggering the release of cortisol. So you're not getting that negative feedback back up. And because you're kind of building up this mineralocorticoid process, you get an increase in aldosterone. On the other hand, if you have a deficiency in 21 hydroxylase, you're blocking off both of these two pathways, and that means you get a decrease in mineralocorticoids and glucocorticoids, but you get an increase in androgens. So aldosterone is released by your zona glomerulosa. It's your main mineralocorticoid, and we'll come across this in all the renal stuff before. It's triggered by hyperkalemia, angiotensin II, and ACTH in a little manner, and it increases sodium reabsorption at your DCT or collecting duct of your kidney. Cortisol is your main glucocorticoid, and it's released kind of actually both by your zona fasciculata and reticularis, but mainly your zona fasciculata. It's 90% bound to corticosteroid binding globulin, so CBG, which is produced by the liver. And then it's metabolized in the liver and excreted by the kidneys. It's got like your usual kind of long loop feedback system to your anterior pituitary. So it can block ACTH, which usually produces or increases the production of cortisol via your adrenal cortex. And it can also block your hypothalamus, so the release of CRH. It's got a circadian pattern because they follow the ACTH pulses, and that means that your best test is a 24-hour urine test, and they really love to test this. And also one other thing to note is that your ACTH is released as another molecule called POMC, and then that POMC is cleaved so that it forms things like ACTH. But in doing that, it also releases MSH, or melanocyte stimulating hormone. And that means that an increase in secretion of ACTH will also increase your MSH, and that can cause bronzing of your skin. And dexamethasone is used to inhibit ACTH, and that's involved in some testing that we'll go through a bit later. So you get increase in cortisol or your stress hormone via obviously things like stress, CRH and ACTH in here, and then it's decreased via your cortisol. Its action is on glucocorticoid receptors, but sometimes it also has actions on mineralocorticoid receptors, which means that it can have some aldosterone-like effects. Overall, it's pretty catabolic, so it's going to cause your body to break down. So things like muscle wasting, things like lipolysis, your skeletal muscle also breaks down a little bit. Yeah, and so it'll increase your blood glucose. But at the same time, you gain fat. And that's because you get lipolysis, but it's redistributed to other areas of your body. And you also get an increased appetite. In terms of, I'm gonna run a power. You get hypertension, you get an increase in cardiac output, and you can also get cardiomegaly. For CNS, you have an increase in attention and memory, because you can imagine if you're like under a lot of stress, you need to work better. And then it is important in cellular differentiation as a fetus, so like growth, especially of the lung. But in excess, so like when you're not a fetus anymore, and you have too much cortisol, it's going to inhibit growth. It also causes immunosuppression, decreased sensitivity to pain, and decreased serotonin. And these, essentially, if you remember this, then you know what's wrong, right? When you have more or less cortisol.
Just to quickly add something before we move on too far from where I wanted to add it. If the steroidogenesis stuff from before, when Jay was talking about the 17 alpha hydroxylase deficiency and this 21 hydroxylase deficiency, that's also called congenital adrenal hyperplasia, or CAH. For some reason, I like talking about it quite a bit, but basically it's because of the end products that they can cause. So think about it as a kind of a blockage of what causes next. And that's kind of like how you can think about it. But these are both causes of congenital adrenal hyperplasia. 21 hydroxylase is just the more common type. That's the one they typically talk about more when they talk about congenital adrenal hyperplasia, or CAH. But yeah, that's what I'm just going to talk about.
Yeah, and you'll come back to this in repro as well. Alrighty, so Cushing's syndrome, and it's not disease, it's syndrome. That's an excess or an increase in your glucocorticoids or your cortisol. 80% of it is due to Cushing's disease. And Cushing's disease refers specifically to an ACTH secreting pituitary adenoma. Another important cause is an iatrogenic cause, and that's when patients are given glucocorticoids because it's a really good immunosuppressant, which is required in some management. A primary etiology will be a dysfunction of the adrenal gland, and a secondary etiology will be an increase in ACTH via the pituitary gland. So it's a pituitary gland issue. And the symptoms kind of like literally just the actions of cortisol, but it's exaggerated. Some really characteristic things that you should remember should be the moon face, the buffalo hump. You get osteoporosis and fractures. They get these abdominal striae. They get acne. They can get neurological issues, so like depression, psychosis. They get hypertension, easy bruising, poor wound healing, weakness. I think those are the most important ones. Oh, and increased abdominal fat. And then if it's secondary, so if it's due to a pituitary issue, you can also get an increase in MSH, and hence you get like skin pigmentation, a darker skin, bronze skin color, and you can also get amenorrhea. For management, if it's iatrogenic, then just make sure that they're weaned off slowly off their glucocorticoids to prevent a severe drop. You should reduce it. And then if it's due to Cushing's disease, then you should remove the adenoma. So how do you diagnose it? How do you investigate it when you suspect something like this? You do a dexamethasone suppression test. So if you think back to just here, we said that dexamethasone inhibits ACTH. So that's the hormone causing an increased release of cortisol. And that it does that by suppressing the pituitary secretion directly. So first you do a low dose or 1 milligram dose. You give them a little bit of dexamethasone to see whether they have Cushing's syndrome. So that's just an increase in cortisol. And so if you're normal and you don't have Cushing's syndrome, it'll suppress your ACTH and you'll get a decrease in serum cortisol. But if you have Cushing's, then that little bit of dexamethasone will be insufficient to actually suppress enough of your ACTH. And so you still have a relative increase in ACTH and a relative increase in serum cortisol. And so if this is the case, you do a high dose dexamethasone suppression test. So you give them more, 8 milligrams, to find the cause. And so if they have Cushing's disease, which is the pituitary adenoma, then you will get that high dose will be enough to suppress the ACTH. And so you'll get low serum ACTH. And because of that, your cortisol also decreases because it's only in reaction to the increase in ACTH. If it's an adrenal adenoma, then essentially it's already low because your adrenal adenoma is the one that's directly secreting cortisol. And so your cortisol is already negative feedbacking and causing a decreased ACTH. So further suppression means that it's low already, nothing changes, but your serum cortisol is still high. And then if it's an ectopic ACTH producing tumor, so a random tumor anywhere in the body producing ACTH randomly, you will not suppress the ACTH because it's not the pituitary. And so the ACTH will still be high and your serum cortisol will also be high in response to that. And then for blood tests, you can, you would look at your cortisol and ACTH, but you remember that your best test for cortisol is a 24-hour urine test, and then imaging a pituitary MRI or an adrenal CT for an adenoma. Addison's is the opposite, so it's when you have a cortisol deficiency. Like before, you can have primary and secondary etiologies. So primary is hypoadrenalism, so dysfunction of the adrenal gland, and secondary will be due to a decrease in ACTH via the pituitary. Iatrogenic causes are also like there. So, and that's when you have too much exogenous steroids. So you're giving them too many steroids over a long period of time. For example, if they have something like rheumatoid arthritis and you need to suppress their immune system, then they can't make enough endogenous steroid when they need to, when they're taking off their medication. Symptoms, I'd say the most important ones to note would be things like weakness, bronze pigmentation due to a reflex increase in ACTH causing an increase in MSH. They get a postural hypotension, weight loss, hypoglycemia, some GI disturbances such as nausea, vomiting, abdominal pain, depression as well. So just make sure that when you're giving people corticosteroids, you wane them off very slowly, essentially. And lastly, androgens, it's released by your zona reticularis, and it's related to repro stuff. And your adrenaline and noradrenaline from your adrenal medulla, both catecholamines, and involved in your SNS. I'm sure you've done this to death, so I won't go over it. Pheochromocytoma is when you have a tumor of the adrenal medulla or sympathetic ganglia, and that causes excess adrenaline. It's pretty rare, and the symptoms are essentially just your SNS. So you're thinking anxiety, panic attacks, hypertension, tachycardia, palpitations, tremor, headache, flushing. So there. I think this is the end. So do we have any questions?
If not, thank you so much for watching our presentation. I think we can stop recording now, I guess. But yeah, thank you so